Welcome, everyone. This is the International Foundation for Integrated Care virtual community. Today, we are focusing on advancing integrated care with digital health innovation. We have close to 500 people registered today, and we are looking forward to welcoming all of you. A warm, warm welcome. And you can see the numbers going up. We are nearing 140 people, and as more people come on, they will be let into the room. And I love watching the numbers rise. For those that haven't heard yet, a warm welcome to the International Foundation for Integrated Care Canada, our session on advancing integrated care with digital health innovation. We are very excited to welcome you and have you join us today. I'm Jodeme, and I have been part of co-founding the International Foundation for Integrated Care Canada. It is a North American Center for Integrated Care, along with Dr. Walter Wodchis. Hello, Walter.
Hello, everyone. Welcome. Happy to see everybody joining us again today. And we also have with us today a special co-host, Dr. Carolyn Steele Gray.
To get started, we like to say hello to everyone. So as you have logged in, can you now go to your chat function and under to everyone, make sure you do not just click to panelists, but to share to everyone, say hello, your name, and where you're logging in from. Our last virtual community was global, and today we don't expect any different. So you can see that we have people joining from Ontario Health Teams, which is Ontario's policy lever or policy vehicle for integration. And then we also have people joining from all over the country and around the world. Look how quickly you're coming in. Austria, Ireland, BC, Alberta, it's going faster than I can even articulate, which is quite exciting. And you can see also people join who are citizens, who come to an equal partnership to partner around integrated care and population health and well-being, and those that work across the full continuum of health and social care, including policymakers, researchers, and others. So a warm welcome to all of you on behalf of us and IFIC Canada. Next slide, please, Yinka. Again, a reminder that the way we structure these virtual communities, they are not didactic. We are meant to create a sense of belonging, connection, and community as a way to mobilize knowledge and connect us up in shared purpose and to build all of our shared capability to support integrated care, with the ultimate goal of improving population health and well-being. And as the most emergent evidence shows, if we don't do it in a relational way, then it's very hard to change culture, capability, or to sustain the kind of impact we want to have together. And so this is a virtual community, and we leverage the chat function. The chat function is for you to share your reflections as presenters are speaking, to also ask questions where Walter, Carolyn, and I will be looking through this, and then to share resources, and we curate all that material and share it back with you. The ways in which we share is through the International Foundation for Integrated Care website. We are the IFIC hub, the Canadian hub. So Yinka, please turn the slide. And you will see that there is a resource for how to access all of that. And before we share those particulars, I'd like to turn it to Walter for our land acknowledgement today.
Thank you very much. And I'm seeing people in from all over the world, from Ontario, from Edmonton, from Spain, from Turkey, from England, all over the world joining us today. So welcome, everybody. So pleased. In Canada and here in Ontario, we acknowledge that the land, that we are colonists on this land, and the land that I am hosting this from today at the University of Toronto is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. We acknowledge that Toronto was covered by Treaty 13 with the Mississaugas of the Credit. Canada is home to many diverse First Nations, and I've seen some in the chat also acknowledging the lands that you are from. We welcome you to acknowledge the land that you're joining us from. We're home to many diverse First Nations, Inuit and Métis people, and each of you are joining us from various territories today. Thank you for coming to today and joining us. And if we start off, we're going to see whether people have joined us before, and we like to open up our events with a poll. And so if you can go on and click into whether this is the first time you've joined us for an IFIC Canada virtual event, or whether you've joined us previously. So is this your first time joining? Yes. And actually for the no, we have to fix this poll question. I don't know how this, no means that this is not your first event. I'm sorry about the wording on that. So yes means it is your first time joining us. Oh, that's a great double. You can only answer one way to this question if you look at it carefully. Okay, so why don't we share those results out? And it looks, because I've definitely noticed some new people joining us this time, and we see about 64% joining us for the first time, and about 36 saying, no, this is my first event. So that could mean one thing or another. Why don't we go along and just acknowledge the many people that are helping support this in the background today, many of them online, Trisha, Deb, and Yinka, all supporting today, Niamh Day and Fiona from IFIC Central in England, and also in actually Ireland mostly. And also Ingrid has been supporting this particular event today around digital health at Sinai. We are so pleased that you'll be with us. And why don't we just take a few minutes and then we'll come back and start off today's event. But first, Jodeme to talk through a little bit about IFIC Canada.
The reason we want to share more about IFIC Canada with you is because our hope and dream is this is our North American platform to connect up everybody who is passionate about and working in or receiving care and partnering in care around connecting up our health and care system so they're experienced as one team and focused what's most important to people and their families. And for those that are new, this is an open space. This is an accessible and free space because we believe knowledge mobilization and building capability is our shared responsibility together, and we want to learn from each other, and we believe we have the capability within our country and across North America to do this, learn from each other, and have collective impact or a bigger impact. And so that is the backbone and the principles by which IFIC Canada works. And we are here in service to connect up and share learnings and have this co-defined by each other around what we want to hear and what we want to focus on and learn together. This topic today was actually brought by the virtual community itself. And we share all of our resources. And again, it is accessible to everyone on the IFIC Central website. This will be sent out to you after with a live link, and to please go into the IFIC Canada Hub, where you will have all previous virtual communities where we've curated the content, including the chats and participant feedback, so you have access to everything. In addition, IFIC Canada hosts a conference. We held our first conference, and all the material from that conference is available to you. And one of the pieces we would like to emphasize are the opening keynote sessions that are very relevant and some of the most emergent thinking and doing as it relates to integrated care. All of that is live for you, plus all the session abstracts and some of the videos from the sessions themselves. So you have a huge resource for the work you're doing or where your interests are, but also a way to let us know what else we could be working on and how to provide more accessibility. And you'll see in the chat that Deb just shared the link to how to access all these resources.
Great, thanks so much, Jodeme. So we do hope that you'll be able to go back and look through some of the curated materials, and this material will be posted thereafter, including video and slides from today. We have a number of areas that have been nominated by participants in these online events in the past. Digital health is definitely one of them. And it's been a real interest of many people in understanding this. We have the great pleasure that one of the co-leads of the special interest group in digital health is from Canada, and that's Dr. Carolyn Steele, who is also invited to guest edit a special issue of the Journal of Integrated Care around digital health innovations. And so that's really been the opportunity that has brought us here today. And I'd like to turn it over now to Carolyn to introduce the specialist interest group and also the special issue, which has brought the speakers today. But I think, Carolyn, you're also going to start off a little bit of a poll yourself that I think has no glitches.
Thanks so much, Walter. And so nice to see lots of new and also familiar faces saying hi in the chat. And I get the great pleasure of having another poll. So the question we have next for you is, how knowledgeable are you about the role that digital health innovation plays in advancing integrated care? I'm so curious about how people will answer this one. And I have a reflection on how I think about answering this one myself. And it's pretty exciting to hear that this is a topic of great interest. I think even more so in the last couple of years, as we've seen quite a bit of an explosion of digital health tools, not just in integrated care, but in our health systems globally, due to often necessity. But it's changing the way we're thinking about it. And I'm excited about this conversation today to see where we're at today and where we can kind of vision the future. So why don't we go ahead and bring the poll answers up. We've got lots in that middle category of somewhat knowledgeable. And I love that response because as I was thinking about it, I feel like some days I feel very knowledgeable and some days I feel like I'm not knowledgeable at all. And it's with that if we go to our next slide, that kind of influenced our desire to bring together a special interest group through IFIC Central. So it started a few years back with myself and Leo Lewis with digital health enabling integrated care, and expanded to bring in Ingo Meyer and expanded our understanding about digital health tools in the space of integrated care as an understanding of digital services and data enabling integrated care. And as we've brought together this group and we've run some webinars and we've put some commentary papers together and we've been getting some great interactions with our community internationally, we do oscillate between feeling like we know a lot of things and yet there's still so much to learn in order to advance our understanding of where these technologies and where these new modalities of interacting can shape the way we think about integrated care and the way we move our health systems forward. So I'm kind of representing that group today, but I also get the opportunity to represent my co-editors for the special issue that Walter mentioned before. And it was a great honor to be invited from the chief editor of the Journal of Integrated Care, Axel Kahn, who I know is with us today, and to bring together this wonderful team of guest editors from international spaces, Irina Efimenko from Sweden, Jordi Piera Jimenez from Spain, and Nick Gildeman from the Netherlands. And we were asked to bring together a special issue that tried to unpack some of this space of digital health and integrated care. And what came through were 12 just beautiful papers that align nicely around 3 real buckets of interest that we heard from our special interest group members as well, around the development and design of technologies, around the implementation of those technologies in integrated care settings, and around the evaluation of those as well. And when we looked across these different papers, and as we say in our kind of commentary section, is that what we saw was really a story of movement. It was a movement of people as they moved in and out of services, movement of our systems and our processes as we shifted workflows and teams and organizations to better integrate health and social care services, and then movement of information and data to allow for people to move and for those processes to move. So we brought together today an example from each of those 3 buckets on the development, implementation, and evaluation of integrated care, which not only tells us where we're at right now, but each of these 3 we find are really the future thinking examples of what we see in the special issue. And then we get to round up this conversation with a reflection from Hilary Horlock, who's been a wonderful patient partner, not just for for us here in this webinar, but for IFIC and the Integrated Care Academy. We've had a chance to work together before to bring in the very important patient and community perspective on what all this means for patients and how do we keep them front and center as we put these technologies into place to enable our models. So if we go to the next slide, here are our today's speakers speaking through our 3 lovely papers. And I get to start first by introducing Eva Turk and Viola Wanton, who are going to talk about co-designing technologies, co-designing through user-centered design, health information solutions in their environments. Eva and Viola, please go ahead.
Thank you so much, Carolyn. It's a pleasure to be here and to present our work that we did as part of the Gravitate Health project that I'm going to talk a little bit about today. And Viola is then going to go a little bit deeper into the methodology that we used when starting to develop the digital health solution. I moved on from University of Oslo, and I'm now somewhere else, but this work has been done when I was still at the University of Oslo. So if we go to the next slide, please, and to say what actually Gravitate Health is about. It's an innovative medicines initiative funded project. It's a public-private partnership. And what we were really aiming to do is to empower and equip the European citizens with health information for active personal health management and adherence to treatment. So the main question that we really asked ourselves at the beginning is how can we apply an open access digital platform with trusted digital health information to transform the way patients access and understand health information and apply this in personal health for adherence to treatment, risk minimization, and quality of life. So just to demonstrate this, our persona is really Maria, who is a Norwegian elderly lady who struggles with her medication as she is having more than 15 medications that she needs to take on a daily basis. So the first picture actually shows her medication list that she made herself. And the second is demonstrating how she then needs to read through the product leaflet. So the idea with the Gravitate Health project is to actually focus the electronic product information and connect it to our health records and working with the health education materials. So who are the people behind the Gravitate Health project? You can go to the next slide, please. There are 40 partners in Europe and the United States of America. We have 11 ecosystems that Viola is going to tell you a little bit more about. It's a big European project with 18.5 million euros, and it's running over 5 years. Now it's the second year running. What is also very, very important is, in addition to having the European start and the global outreach, is also that the project is working with members of the user advisory group. And this user advisory group has been involved in the project really from the beginning. So it helped us really start creating the first MVP. And if we go to the next slide, please, we can see how the steps that the project is taking towards the digital solution. So first of all, everybody contributes. Then it's on this is the co-creation. It's the collaboration where we take the diverse inputs and feedbacks from the user advisory group. We focus on the outcomes. This is then really having the shared vision and goals. And it's a constant iterative progress with small increments and iterations. And now I'm going to give the word to Viola, who's going to then take you deeper into the methodology that we have been working with. So Viola, the floor is yours.
Thank you so much, Eva, for the introduction to the project. Thank you. Have you ever found yourself coordinating a highly complex and diverse stakeholder ecosystem on the project? Maybe it was a project with multiple teams, departments, or even countries involved. Was it simple and straightforward process, or did you find it challenging to navigate? I ask this question because I believe that many of us experience the complexities of working with a diverse range of stakeholders. And when it comes to matrixed organizations and highly complex ecosystem, it can be challenging to achieve a shared perspective and common priorities. In such scenarios, traditional approaches to problem solving may just not be enough. And this is where human-centered design comes in. From the research phase, where empathy is cultivated through conversations and observations, to the ideation and prototyping phases, where ideas are tested and refined, human-centered design provides us with a set of tools that put people, empathy, and curiosity at the center of the problem-solving process. It also provides a safe space so that all perspectives can be taken into account, and a shared understanding of the problem can inspire more impactful outcomes. Now, human-centered design is not just a methodology, it is also a mindset that recognizes the importance of creativity to unlock the power of ideas that logic alone sometimes cannot reach. The visual on this slide is just a snapshot of the kind of tools and techniques that our members of our consortium used to align around common objectives. If you are curious about some of the examples listed here, I would like to invite you to look at the Maria persona and her journey within the article that we're discussing here. Next slide, please. If you can recall working on a problem similar to ours, perhaps, that seemed too big, too abstract, or too ambiguous, or impossible to solve, what was your experience like? Perhaps you were given a deadline and the pressure was just mounting, but the solution wouldn't just come to you. One of the greatest minds in history had an approach that could help. He said, if I had an hour to solve a problem, I'd spend 55 minutes thinking about a problem and 5 minutes thinking about the solutions. What Einstein was trying to say is very similar to what has been highlighted here in this double diamond human-centered design process, which became a blueprint to our project work. It emphasizes the importance of clearly articulating the problem before jumping to solutions. It holds us in the problem space. This double diamond process is based on two fundamental questions. The first one is how to solve the right problem and how to solve the problem right. And this is the first step to ensure that we are addressing the right opportunities in a way that meet the needs of all stakeholders. So let's dive in a little bit deeper. Next slide, please. Okay, could we jump a little bit forward? Thank you. So our exploration started with the framing and planning phase. To help us understand specific patient needs, priorities, and preferences, we conducted a series of interviews with patients across multiple healthcare ecosystems. We used Delphi study methodology to identify the most important needs and matrix to support patients' outcomes and opportunities throughout the healthcare systems. We then used prioritization surveys to gather a broad spectrum of requirements, ensuring that the project addresses the diverse needs of patients in a focused way. And through this research, we developed critical success factors and KPIs and established like a guide almost, or a North Star, to the incremental design and development of the project, while also ensuring that compliance is met with the healthcare standards and regulators. Once we reached the consensus on patient needs, priorities, and requirements, we initiated the process of assessing, integrating, and evaluating the functionality of our solution. And to ensure the usability and adoption of the platform was met, we actively engaged a dynamic, growing community of patients and healthcare professionals through the user advisory group that Eva has mentioned before, including collaborations with various stakeholders across 11 global ecosystems. In this process, we learned that individuals are more likely to back initiatives that they contributed to creating. When people are directly involved in creating something, they feel a sense of ownership and develop emotional connection to the work. It makes them more invested in its success and more likely to support it. It becomes personal and people start to care about the outcomes. The sense of accomplishment that comes from being part of the project is a very powerful motivator. Our co-creation efforts not only allowed us to gain valuable insights and feedback, but also allowed us to continuously refine our design and also clarify our requirements even further. Definitions of user experience and platform architecture have been captured in technical requirements, and the evaluations are currently taking place in more than 8 countries using evaluation by design methodology with a focus on cross-regional reference and interoperability. Currently, we are designing the UX mockups in 2-week sprints, working with the user advisory group monthly during our design workshops. And as with all the design and development activities, we are also actively reaching out to other partners, startups, and organizations to take part in co-development activities using global connectathons as a platform, also interoperability showcases, as well as the upcoming hackathon to advance the platform's functionality and also increase potential for sustainable impact on our outputs. As we progress the development of the early implementation, as Eva mentioned MVP, we recognize that success is not just about the result, it's also about the journey. And it's just not enough to simply develop a product and hope that it will be adopted. We fully intend to take intentional steps to evolve and expand our ecosystems and generate visibility and engagement amongst all our stakeholders across all those diverse ecosystems, and to drive targeted efforts that will ensure the sustainable impact of our project. Thank you for listening. I will now hand over to Carolyn.
Thank you, Eva and Viola, for that lovely quick walkthrough of your wonderful paper. I think what's really exciting about this for me and for the guest editors of this issue was the centrality of patients and providers, not just in how you were thinking about designing, but how you were even thinking about understanding the problem in the first place. And I think that's a really powerful way of understanding not just traditional user-centered design, like tell me what you need, but it's about kind of co-creation and co-ownership of what even the challenges you're trying to solve, and having these iterative ways of implementing and evaluating as you're going through the design process is very powerful, and sets us up really nicely to have a conversation about implementation. I do note a really important question from Alan Katz in the chat, and I hope so, one of our panelists can jump on in and answer this question of language availability of technology, because I'm sure our panelists have been asked that question before and can jump on in. But next up, we're going to go into implementation. And this paper was also very exciting because it deals with an implementation challenge we don't often talk about in technology around education and training. And they bring to, and Jane and Maria Myalopoulos bring together a really beautiful framework for understanding education that can be delivered through technology, but also advance technology as well. Jane and Maria, please go ahead.
Thank you so much, Carolyn, and thank you to the IFIC Canada community. It's really such a pleasure to be here. So hi, everyone. My name is Jane Zhao, and I'm a research associate with ECHO based at University Health Network, which is in Toronto, Canada. I'll be speaking on behalf of myself, my co-author and the fellow panelist, Dr. Maria Milopoulos, who's a scientist and associate director of training programs at the Wilson Center, a center dedicated to the advancement of healthcare education and practice through research. Next slide, please. Together, we wrote a paper called "What Role Can Education Play in Integrated Care?" And sneak peek, a really big role. Lessons from the ECHO Concussion program. Actually, if you just click this once, thank you, Inga, in which we argue that the ECHO model is a novel digital health solution that uses technology-enabled learning to facilitate, support, and model integrated care education. And it was also a way for us to expand and contribute to the ECHO literature by creating a link between the ECHO model and integrated care. Next slide, please. So what is ECHO? For those of you in Ontario and Canada, and perhaps even globally, you might have heard about this program. So ECHO is an acronym that stands for Extensions for Community Health Outcomes. It's a model for health professions education where we use digital health, and in this case, Zoom, which you can see kind of small on that far screen in the picture there, as a means and platform for education sessions. This model began in the United States by Dr. Sanjeev Arora for hepatitis C management in 2003 and has since expanded globally to over 60 countries and over 65 disease and non-disease other topic areas. In Canada, we started the first ECHO program in chronic pain and opioid stewardship at University Health Network in 2014. And since then, there are now over 35 ECHO programs in across 6 provinces in Canada, and ECHO Concussion started in 2019. Now, how each ECHO session works is kind of what you see in the photo here, which is the live shot from inside our hub room, back when we could still be in a room together. So ECHO uses a one-to-many model where we have our academic specialists. So these are people who are physiatrists, neurologists, pharmacists, chiropractors, etc. And they work within usually an academic hospital, and they connect with healthcare providers across the province, in this case, Ontario. And our ECHO Concussion Hub consists of professionals across 9 different health disciplines, including medicine, pharmacy, physiotherapy, and occupational therapy. And not only this, our learners are also reflective of this multidisciplinary hub, attending from over 15 different health professions, from physiotherapy to family doctors to pharmacists and nurse practitioners in the community. And we've also had a few social workers as well as health psychologists attend our sessions. Each ECHO session, oh, not yet. Thank you. So each ECHO session offers CPD credits and is at no cost to the learner. Each session includes a didactic portion, which is usually around 20 minutes. And this includes a Q&A at the end, where oftentimes we'll open it up for the community, as well as, and this is on a set topic in a curriculum that we have approved at the beginning of the cycle. And then we also have a patient case presentation from a clinician in the community. Even though our clinicians often come because they think that they want the learning from the didactic sessions, oftentimes what we find is actually the learning occurs really in the discussion around the patient case. And that's really an opportunity to think together about a real patient case and discuss management options. At the end, the clinician is then provided a list of recommendations that our community and our hub team come together and generate. So we found that ECHO improves clinicians' knowledge, confidence in management of complexity and different patient cases, as well as developing a community of practice. So what does all this have to do with integrated care? Next slide, please. Thank you. What we observed in the integrated care literature was really a lot of discussion around the development, the implementation, the evaluation of integrated care programs, and even, really conceptualizing what is this topic and what is this space. But we didn't really see a lot of discussion around education of the healthcare workforce to be able to enable, support, and sustain integrated care once implemented. And even though ECHO isn't a program for integrated care or about integrated care per se, although I think there are some discussions with the Ministry of Health in Ontario around developing an integrated care ECHO. We did see many relevant links between ECHO and integrated care that we wanted to highlight. So this is a model, a framework that I'm sure many of you are familiar with, the Rainbow Model for Integrated Care that Valentine et al. Developed. And we really kind of saw these different levels of integration. So from clinical to professional, organizational to system, as a way of scaffolding how education might play a role in integrated care. So on the micro level, there's clinical integration, which is a person-focused perspective to improve someone's overall well-being and not just focus on a particular condition. On the meso level, there's professional and organizational integration. So that's the extent to which services are produced and delivered in a linked up fashion, as well as development of interprofessional partnerships based on shared competencies, roles and responsibilities and accountability to develop a comprehensive continuum of care. And then in terms of system integration, that's really the approach to enhance efficiency, quality of life and care, and satisfaction through vertical and horizontal integration. Next slide, please. So this is really where we actually started to operationalize how exactly would ECHO as an education program really meet and interact with the integrated care model. So on the micro level, what we really saw was in terms of clinical integration, the clinical integration really occurs through case-based learning, and this is through the patient case discussions that happen every week. So when a clinician from the community comes and presents to us a complex concussion management case, where perhaps this person, if they are a youth who is now coming in with multiple concussions and they need a plan for going back to school, the discussion that unfolds around is really around this development of adaptive expertise. And what this is, what this term is where learners develop where learners benefit from productive struggle and emphasis on WISE, which is the integration of basic and clinical science, as well as, yes, thank you. As well as the emphasis on WISE. So the integration of basic and clinical science and what ifs. So this is the variation in different clinical presentations. Clinical integration occurs when learners move through productive struggle together and come to us beyond a single solution, developing a nuanced understanding of patients and their contexts of where they live and where they have to, and their communities, which couldn't be achieved through just a single discipline. If you remember back, the ECHO Hub is oftentimes multidisciplinary, representing many different health professions, as well as the learners who attend. In terms of the meso level, so this is on professional integration, there's development of professional networks between clinics, as well as development of empathy, something that we've heard oftentimes from our focus groups and from qualitative research with our ECHO participants, is that when a clinician, so say for example, a doctor, hears about how a pharmacist in the community might manage a particular case and how they approach certain modes of asking around management and diagnosis, that really a deeper understanding of what each profession does helps foster this development of empathy. And the same for when a pharmacist listens to a nurse practitioner or clinician or a physician talk about how they might approach a particular case. That's also development of interprofessional collaboration as well as empathy. And now also interestingly, in terms of organizational integration, this is where development of the specialist generalist occurs. And the specialist generalist is a term that we use and it's defined as the ability to support care for a wide range of patients in primary care settings. So you can think about this as the family doctor who's seeing not only the concussion patient, but also the chronic pain patient, also the Hep C patient, also a patient who's a refugee coming in and a newcomer to Canada. So these are all different pieces that come together on perhaps the same patient, and also a development of stronger interprofessional networks within their own clinics. So in Ontario, there are many different primary care models, and many of these are centered around interprofessional teams. So this includes a family physician, a nurse practitioner, a registered nurse, pharmacist, perhaps an in-house psychiatrist or other medical specialists as well, oftentimes dietitians, OTs, and PTs, or sorry, maybe not PTs. And then all of these are then come together and again, talk about the same patient, and they're able to work together in a stronger, more coordinated fashion. And then finally, in terms of macro level, the system integration, the education that providers are receiving, we really kind of cut across between primary care to quaternary care. And then through the establishment of lateral peer-based networks focused on population level health, this is where we see system level integration occurring. Next slide, please. Thank you. So just finally, one last point about integrated care education. We really think about this as the meaningful learning that purposefully supports collaboration and the development of adaptive expertise in integrated care. Again, the conversation that we think is occurring within the integrated care space is incredibly important and so useful in terms of the development, evaluation, implementation. But what we see is lacking is around this piece of, okay, how do we educate the healthcare workforce and perhaps the healthcare managers and administrators to be able to support and sustain the important work of integrated care? And then finally, a definition for adaptive expertise, which is a framework for conceptualizing how expertise develops as both procedural knowledge, so knowing what to do, and conceptual understanding, knowing why you're doing it. So again, this comes back to this idea around productive struggle and emphasis on whys and what ifs. Okay, next slide, please. Thank you so much, and we really look forward to the discussion.
Thank you so much, Jane and Maria, for this really exciting paper. I really appreciated the linking of the model of education to integrated care. And it builds very nicely on the last conversation around kind of this shared understanding that can happen through indeed design and development, as was previously talked about, but also through this education space and this ability for providers and patients to understand each other through this concept of productive struggle, I think is a really powerful idea as we both design and implement technologies or new models of care across very diverse perspectives and different kinds of stakeholders that might have different notions of where we're trying to get to. But bringing each other together through the notion of productive struggle, I think, is a very powerful view. Thank you so much for that, and I look forward to continuing this conversation with the team as we go forward. But it's also my great pleasure to move on to evaluation, and I know this is a big topic for a lot of us in the digital health space. We quite struggle with how we evaluate, and I'm so excited for Gerard Carasans to join us today from a very advanced model of technology that they have deployed in Catalonia, Spain. One of my favorite international examples to share, particularly with our Canadian groups who are seeking where Catalonia is and has been for about a decade. So Gerard's going to talk us through this evaluation when things have been put in place and what they've learned about their models when they've been in place for a long time. Gerard, please go ahead.
Well, thank you, Carolyn, for this nice presentation, and thank you, the IFIC Canada, for inviting us to share with you our results. So just a few slides, just the why and what of this evaluation of this integrated care program. So if you can move to the first slide. Well, this diagram represents kind of our vision. So we try to move towards a healthcare system which can learn from research. So take some evidences from research, put them in practice, and then evaluate. So gather data from the healthcare system and then refine and improve this evidence. In the next slide, this is the starting point of our use case for this evaluation, which was an integrated care program for stroke. So we knew from the evidence that patients who experience stroke event and are hospitalized can very much benefit from continued rehabilitation and support after discharge, and this makes a difference in the health outcomes and the amount of activities of daily living that these patients recover. So in the next slide, we can see what was the usual care pathway of patients with stroke. So these patients are admitted to the hospital. They stay sometime in the hospital, and then they are discharged to home. And in the next slide, we see that in this usual care, at least in our country, this assessment of social needs, of potential social needs, is performed at the very end of the hospitalization process. So just 24 to 48 hours before discharge, the social care teams make this evaluation of social care needs and decide whether this patient needs personal support at home, so housekeeping, or technical support or whatever. So we decided to change, to switch from this scenario to another one in which we anticipated these social care needs. So we decided to start making this evaluation right after admission and anticipate the needs at home and support that these patients will need, and start prescribing and starting all the process of this social support. And all this was supported or was facilitated or enabled. If you go to the next slide, was enabled by the previous, sorry, one before, yes, was enabled by this central electronic health or integrated electronic health record, health social record, that took and gathered data from the healthcare system and from the social care system, which is not provided by the same administration in our country. And I think this is the case of many other countries. Social care is provided by the city council, so by the local administration, which makes sense because most of the times are providing support to citizens, not patients, and is the administration which is closer to the patient. Whereas the healthcare is governed and managed by the country or big area community administration. So we created this common electronic health record so that this evaluation of social care needs could be done at the beginning of the admission. Next slide. So people, professionals, and everyone was very happy with this integrated care program, but we wanted to evaluate and quantify what were the outcomes or the difference between having this program or not. So we implemented this integrated care program in a few hospitals, and after we got the first 92 patients or the first experience, so we decided to compare the outcomes with people admitted to hospitals, not within this integrated care program. Next, please. So we took data from almost or nearly all hospitalizations due to stroke in Catalonia, and we screened these people. We get to finally 1,400 candidates for pairing. So after excluding all people that died there in hospital or were not from Catalonia, so we didn't have data from the primary care setting, etc. And of course, we created a control group pairing, but by some characteristics that are important to compare the outcomes, because of course the outcomes of stroke patients will vary according to age, according to sex, the comorbidity burden, and most importantly, the type of stroke. So in order for these outcomes to be cleanly compared, we adjusted by these variables, and we took this control group and we compared the outcomes with the participants in the pilot integrated care program. In the next slide, we can see the percentage of patients in each of the group receiving domiciliary care, so receiving support at home. In red, you can see the percentage or the progression of percentage of patients over time in the integrated care program, and in green in the control group. So as you can see, individuals in the integrated care program were much more likely to receive support at home than patients in the control group. In the next plot, we see a similar progression of this percentage for telecare solutions. So as you can see at the beginning, there are some patients that in the control group that very quickly start to receiving this telecare, but in general, people or patients in the integrated care program are much more likely to receive this service. And finally, at home rehabilitation, which is a key service for these patients to recover the ability to perform activities of daily living. We see here in this plot that not only patients from the care in the integrated care program are more likely to receive at-home rehabilitation than control ones, but we also see that the patients in the control group tend to, at the end of the period, tend to receive as much at-home rehabilitation as patients in the integrated care program, meaning that probably these patients needed this rehabilitation, but there was a delay in receiving this at-home rehabilitation. And finally, in this last slide, we look at first a very hard endpoint such as mortality and see whether this integrated care program improved these hard outcomes. And we saw that it wasn't the case. So people attended within the integrated care program had similar mortality rates over time than the control ones. But another outcome that we measured was the admission or institutionalization in a nursing home. And as we see in the plot on the right, individuals entering in this integrated care program were less likely to being admitted in a nursing home, or did it much later than patients in the control group, meaning that probably these patients had recovered more abilities to perform their activities of daily living and therefore more autonomy. And this is important not only from the point of view of the patient who these patients that living at home are probably had higher quality of life, but also from the point of view of the entire system, because admission in a nursing home is quite expensive for the system. So this is also a benefit for the entire healthcare and social care system. So the manuscript is, of course, more exhaustive in reporting these results, but for this webinar, we selected these outcomes to discuss and to showcase this use case. So thank you very much. I saw many questions or comments here in the chat, but I didn't read them. I hope we will discuss afterwards. Thank you.
That's okay, Gerard. You'll have a chance to go in and take a look, and we'll be able to chat a bit about it in our panel discussion. I think what's exciting about your paper and your team's paper is that it not only outlines technology in the integrated care model, and that is used as part of the model through telemonitoring and other services, but the ability to have connected information allowed you to do this evaluation in the first place, to be able to identify your population groups and see whether your models were having an impact that you expected. So it kind of shows us a couple of uses of digital technologies within an integrated care model and gives us a kind of future thought for those of us in Canada still seeking those types of interoperable integrated systems. And so with that, I'm so curious and excited to hear Hilary Horlock's reflection on these 3 papers, but I know you've also had a chance to look at the issue and we've had a chance to chat about this, and then to pose some questions to our panelists. So Hilary, please go ahead.
Thank you, Carolyn, and thank you so much to the panel. It's been so great to hear these presentations. On the one hand, I am excited by how far we have come. You know, in the spirit of never waste a good crisis, the pandemic had many silver linings for digital health. Things that we had been waiting for years suddenly were available almost overnight. Neglected investments in technology infrastructure and that dreaded technical debt were of necessity prioritized. On the other hand, I am still frustrated by the many roadblocks and the bureaucratic hurdles that are often encountered when significant change is on the doorstep. Not that I like biting the hand that feeds me and pays my mortgage, but sometimes my patient hat gets askew as I shake my head. One of the critical things that I care about as a patient is that I can trust my health system. That's even more front and center with digital health. I expect my health information to be secure and safe. Equally as critical, I expect it to be complete and accurate, and that all members of my health team have the same complete, accurate information about me when they need to make a decision about me. There are still huge gaps of information in my complete health record. Today, in 2023, when my local grocery store can likely tell me what I had for dinner last night, my family physician probably won't know about my visit to an emergency department or an urgent and primary care center for a few days, if at all, until, of course, I tell them. My family physician and all of the regional emergency departments and urgent and primary care centers here are fully digitized, but not on a sharing basis with each other. Across Canada and other countries around the world, there are likely concurrent projects underway in health regions that are producing duplicate functionalities and digital health tools. They are all fantastic individual projects. And the operative word here is individual. Decisions are often made in siloed health portfolios with the best of intentions and the worst of outcomes from a patient continuum of care flow. To this day, even with a whole host of technology and digital tools at all my stops along my care journey, I still have to tell the same story, give the same information over and over. And I am often the information glue between my care team. This is not the most trust-inspiring experience. The patient journey in its entirety should always be at the forefront of any digital health decision. It comes back to trust. Providers need to trust that they have everything they need to make a care decision about me. The people designing the digital architectures need to know that the technology they rely on is available and trustworthy. And patients, we need to trust that it all just works. Patients can be your partners in telling this story. Some of this stuff is hard. Believe me, I know, because I work in digital health every day. But as I tell the technology teams that I work with, the fact that it's hard is no excuse not to do it. Patients already experience the pain of technical debt every day with systems that don't talk to each other, long wait times, having to tell my story over and over and over, the more I know as a patient about what you are planning to do, why it's hard, and how you plan to overcome it, the more trust I have in the future, and the more good humor I am willing to invest in the journey along the way. And maybe, just maybe, a little patience too. So for me, everything that I've been hearing this morning brings up the question of how do we create enabling environments? And my first question for the panel is, how does each of your areas deal with the sustainability of the projects that you are responsible for? Carolyn, you're on mute.
We welcome the panelists to bring your cameras back on and respond to Hilary's question.
Maybe I can start, and then Viola, you can add on. I think especially with at least what I have seen now from the different European projects, and when it comes to the sustainability, this is one of the main parts that actually we already need to put into the projects for the projects to get accepted. So at least in the Gravitate Health project, the sustainability communication and dissemination triangle has been taken on from the beginning of the project. And this has been really, really put emphasis on this collaboration. So we think ahead, like for the business model, how this is gonna go after the 5 years when the project is done. And different groups working together really intensely throughout, also being this part of the iteration process as it's going on. So maybe Viola, you want to add something to this?
I just want to build, I guess, on this triangle of dissemination, communication, and sustainability, because this will increase our potential for sustainable impact as we're going on to new phases of the project. And when you are looking at 40 partners working across 5 years, you do need to keep an eye on the outcomes. And we build on this by connecting consistently within building and increasing and growing a dynamic ecosystems. We've mentioned ecosystems of 11 countries. We've also mentioned 8 testing scenarios where we really actively engage with the healthcare providers and patients, and also the entire digital health ecosystems. So we try to build and test and learn and then iterate as we move on to next phase.
Awesome. That's encouraging, you know, and this kind of systemic change that I've been talking about often relates to policy changes that you might think need to take place. So my second question for everyone is, how would you frame the discussions you need to have with your peers as a means of looking at the future?
Okay, may I take the lead, the first shot? Well, first, we are not doing very well at this, I must acknowledge. So when Carolyn presented us, she said marvelous things about our capacity to evaluate these programs, but then we are failing in the sustainability part. And that's why we are creating these discussions and this place for discussions and looking at the future and see what's happening and how can we improve. So the problem here is that, especially in social and healthcare integration, there are different administrations behind, with different governments behind, and this poses a very severe problem. So we are doing relatively well at the micro or meso level, but at the macro level, at the entire system level, we are failing. So we have recently created this agency for integrated social and healthcare, It's been created just a few months ago, and we hope this will be the platform for having these discussions and making these decisions, and also for trying to moving towards this pooling budget or something that brings together all these administrations so that these solutions can be sustained over time. So that's why that's how we are trying to do. So we have created this agency. Let's see how much can add this agency for social and health integrated care. And in this agency, there are people from the two parts, and also professionals from the primary care setting are playing a very important role, because they are kind of the link between social patients and specialized care. So they play a major role in this.
Thank you so much. We have been paying attention to the chats, and as each of you have been speaking, you can see this rich conversation happening in parallel, where people are sharing their thoughts, their reactions, they're sharing resources, they're making connections. And then our job is to help sense make some of what is coming from the community that's online, and ask you some of their questions. And one of the first ones, which it really happens no matter where you're involved in health and social care and you're looking up connecting pieces, is that with all of these wonderful examples, there are still a myriad of examples of integrated care taking place. And those examples of integrated care with digital enablers and tech enablers aren't necessarily joined up themselves. So when you are a client, as Hilary's talked about from a patient perspective, and others have talked about online, where do you think the opportunity is so that the digital enablers and tech enablers that help support integrated care are experienced as joined up? So if you are a citizen or a caregiver of a citizen receiving care, you're not navigating multiple dimensions and multiple tech enablers. What are your thoughts around those opportunities? And I'd like to start, Eva, you had your hand up. May I start with you, get your thoughts?
Sure. Well, I think with regard to what I wanted to say, it's also building on what Hilary said with regard to the trust, and what we did a couple of years back, a study when we looked into what are the biggest barriers, and the mistrust between the different stakeholders is really one of the biggest barrier. It's not the technological, it's not the financial barrier, it's really the human and social barrier that comes to that. So in a way, what we need to find ways, and one of the platform how we do it is really like a webinar today, is to create the dialogue between the different stakeholders, because this is also how then the different stakeholders learn about what is going on somewhere else, and share good practices, and think about, oh, it works somewhere else, maybe it could work in my setting as well. So that would be my take on with regard to how to start enabling this and creating trust.
Thank you for sharing that. And we've talked about, as part of IFIC Canada, creating an integrated sightline, so we actually understand what folks are doing, so that we can help connect up, so that we can shift the experience to be more connected, despite the incredible work of individual integration efforts. Jane, I saw you shaking your head yes multiple times. Can you share what you're thinking?
Yes, of course. Thanks so much, Jodeme. And I was actually thinking a lot about one of the comments that we received in the chat, I think from Leah, who talked about how useful it would be, or how we actually really need to engage the administrators and policymakers as part of the participants and as part of these conversations, right? And I was really kind of reflecting on how we had previously, invited them in the past. And I think oftentimes, especially in education and integrated care settings, we focus very much on the providers and, okay, these are the patient-facing people and we need them to be the ones who are equipped and educated. But we're also in some ways then missing the people who are more of the backbones, or in some ways more visible to that direct patient-facing experience and how important that is. So I was really kind of reflecting at myself and thinking about how we perhaps either need to start an ECHO or an education program for the administrators and the regulators, or at least invite them to these sessions. I mean, oftentimes we have them as part of the advisory group, but that's not quite enough. And I don't think that goes as far as what we would like. So yeah, I think those are
Thank you,
some of
Jane.
the quick thoughts.
What's critical is that we're all learning together and we're making connections together. And one of our fundamental principles, it has to be done in a relational way. And you can see in the chat, this notion of trust. Change happens at the speed of trust. But in order to establish trust, that means creating the spaces and the way to build. You also will notice in the chat and from those participating that IFIC Canada has made a huge commitment to patient and caregiver partners in the co-design, co-attendance, and co-delivery of every single thing we do. And you hear a lot of the feedback in the chat around connecting these pieces up. Hilary building on why we have to reorient to what is most important or what matters most to people and their families. And despite everybody's incredible efforts around integrated care, if clients and families aren't experiencing us as connected up and focused on what's most important, then we really have an opportunity for improvement and continued growth together. With that, I'd like to turn it to Walter and Carolyn, who I believe will be taking the next summation and round of questions.
Yeah, good. Thanks so much, Jodeme, and really to all the panelists and the participants today. I think have been also very active, and I certainly noticed to pick up Jodeme on the activation of patient voice. And Hilary, I think you also resonated very much with your comments around many of the voices. And I really appreciate the way you've organized today around design, implementation, evaluation. And now I think about, that cycle that was up earlier on around learning health system approaches. And one of the other things that we've seen emerging a little bit lately is also sustainability as a piece. And I was conscious of the project that is a 5-year project and what happens after the 5 years project is done. So I'm gonna come back to those two. I think so. Eva and Viola, around how do you think about that, and then maybe is there a role for evaluation? And Gerard might have a comment on this to play in thinking about that sustainability. So first, Eva, Viola, and then over to Gerard for that.
I think maybe I start this time, if you allow me. I think just building the right foundations with all the ecosystems and stakeholders when you look at the sustainability is very important, but also having a vision, like how will that solution will look like? How do we build it? How do we structure it? And also really understanding and appreciating that every single partner within that sustainability model that you're building and your ambition to scale will have different needs and different circumstances. So how do you also make your solution modular so that the ownership of that solution can be then transferred onto your partner organization, but still the solution holds its integrity? So that's something that we'll be really building around testing our solution across all the ecosystems and ecosystem partners, and different markets will have different maturity within their digital health. So this solution will take shape differently in different ecosystems and different partners. And patients as well, from the front end perspective, may have an app as an end product from our solution, or they might have a service where the front end already exists. So really looking and appreciating, having this empathy around the entire micro services that exist and how do we connect them together so it will build a better future, but in a very modular way and a very kind of individual way based on the requirements for each particular market.
Well said.
Yes, and I think a very important point as well is that within this project, because it's a very regulated market, it is about electronic, product information. It is taking information from the trusted sources. The project is also collaborating with the regulators. We were talking a little bit with regard to the policymakers and so on. So I think this is also like making aware, the broader community, that actually what the project is about and how we are taking the steps towards making it easier for, in a way, everybody.
Yeah,
so to have this focused mechanism, yes.
Yeah, and I think, Gerard, your evaluation is more around the model and not specific to the technology, if I think about that, if you'd agree. And I think Ali's makes that point here in the chat, that needing to evaluate how the intervention supports the outcomes, not the tech in its own respect, right?
Yeah, exactly. When I think there are two key issues for evaluating. One is what do you want to evaluate? I mean, in terms of the outcome. So what outcome do you want to evaluate? Is it individual satisfaction? Is it patient satisfaction? Or is it another more quantitative outcome? If so, you have to gather this data. And this is a previous step that it's a necessary condition for making this type of evaluation. And also in an integrated way. So you have to, because patients can move through the settings and healthcare providers and whatever. So if we don't have integrated information on them, we lose the track of these patients and we lose information from these patients. And I think, Walter, this problem of sustainability is a big issue, because I think the literature is full of experiences that have ended at the pilot phase, right? So perhaps the key here is, I mean, I'm not an expert in a large scale implementation, but I think that the key here is planning. So planning before starting implementing something. No? And there are wonderful toolkits for this. The WHO has this framework or toolkit for monitoring and evaluating digital health interventions, which is also a kind of guidance for large scale implementation. And I think if we can plan in advance what will happen after this pilot experience, it will increase the likelihood of this intervention to be fully implemented.
Yeah, thanks so much for that. And I think encouraged also by Shannon, and there's some taps on Shannon's back there for thinking about sustainability in a broader perspective. And I think that also ties in a few pieces. Carolyn, so what do you think?
So it's interesting hearing this conversation, because I think that the challenge we always come to with digital health is it's playing these two interesting roles within integrated care, right? It acts as an enabler of the moving parts in terms of the way we're sharing information and communicating, moving people and all of those fun things, making decisions, ideally. But it's also a bit of a scaffold and an infrastructure. So a lot of the conversation in the chat is coming around interoperability and integrated information systems, and that is the scaffolding that allow the processes to actually occur that people are talking about. So I think among our challenges of deciding how we're going to leverage technology into integrated care and where we start comes in unpacking, are we talking about the scaffold or are we talking about the movement and the understanding of what we're trying to achieve? So with that kind of in mind, that potential dual role, I'm keen to hear in our last few minutes with this panel, everyone's kind of reflection about where we could maybe pull on a lever that you're working on to move us in a particular direction. So I teach an implementation course. I like to ask my students this, like, if you had one lever to pull that you think is going to move us in the direction of integrated care, one that maybe you understand, which one would you go for? And that will help some of our community thinking about this transformation. And I'd love to start with Maria, because we haven't had a chance to hear from you just yet, and then to Jane, and then I'll prompt our next folks. Please go ahead, Maria.
Sure, thanks, Carolyn. I haven't thought too much about that, but I think that, you know, I'll say from my perspective as somebody who studies expertise and expert development in a broad sense, and with a particular focus on adaptive expertise, I would pull a lever of adaptability. I think we don't want people to be taking solutions and applying them in different contexts without considering the different ways in which those contexts need adaptation and flexibility. And I think that speaks to many of the comments in the chat. They're talking about sustainability, and the whole purpose of adaptive expertise and thinking about how we train future healthcare workers is so that they meet the specific needs of the specific communities and people and patients that they're serving. So I don't know if adaptability is a lever, but if it was, that's the one I would pull.
Definitely a lever. Jane, go ahead.
Thanks, Carolyn. I'm happy to jump in here. I think adding on to what Maria just said about adaptability, not only adaptability within a particular person or a particular case, but I think adaptability between the programs, I guess, and what we teach. So I guess I'm thinking about this specifically in terms of the ECHO program, which I work in. But one of the really remarkable things about this program has been its kind of spread and scale over the years, and how it really is a model of thinking about education that you can lend to quality improvement work, that you can lend to just research and evaluation overall, and to specific areas, right? So whether it's going to be teaching around autism and having family members be engaged as part of that conversation, or it's going to be about chronic pain and opioid management or concussion, I think that piece around adaptability and thinking about the integrated care piece might also be really important.
I love those too, because they allow us to think about the context, not a very specific solution, but how do we adapt our change to context? Looking at the time, I'd love the last reflection on levers to go to Hilary. Which lever do you think we'd like to pull?
I would like to pull on the holistic view of an end-to-end journey, as I have been putting in the chat. You know, as I say, these individual things, they're fantastic and we need them, and they are really, really exciting. But my life as a patient is not made up of moments in time. It is made up of a whole journey, and my interaction with the health system is something that I need the health system to take into account every time it thinks about the way that it's going to present the information to my care team, because they're there because I have a problem or a question about this one thing. I don't know enough about medicine necessarily to ask the right questions, but if you have everything related to me in my end-to-end journey context, and I may be moving from one moment to another moment, but I'm seeing you in this moment, I need all of those things to be part of the conversation so that I can play a more active and helpful role as a patient in my outcome and in improving healthcare for the entire system and population. I think patients can be better partners if we think about our lives holistically.
And Hilary, if I may build on that, what's your recommendation on how?
Well, I work in digital health every day. So there are some fundamental systemic changes that I believe need to take place in the way that we think about funding projects, in the way that we empower the people who are the decision makers around the health system, because they are potentially being asked to produce things relative to a portfolio or a departmental area or something else that is absolutely fantastic, but it's one part of a slice. So if we can start from an education level and from a cultural level, the way that we think about how healthcare needs to be designed and delivered in the future, both from an integrated perspective, but also from a decision maker perspective, better education is better for everybody. And the more we can help people understand that we all do have to talk to each other and make our prioritized decisions in a thoughtful, collaborative manner, and stop funding projects on an annual basis for fiscals, to start to think about what those long-term things are, I think that we're going to have different conversations. And I don't know where that goes yet, but I think we need to shift about the way we think.
Thank you. I want to punctuate the final point and then turn it over to Walter. And Hilary, I'm going to use my own words, but what I'm hearing from you and sort of the most emergent readiness on how to help support integrated care overall, to focus on what's most important and what matters most to people and their families, is we need a huge cultural shift and a readiness, which is creating the spaces and places that allow us to connect up all the elements and be focused on and understand what's most important to people and families, because that is ultimately our shared purpose. With that, turn it to Walter. Yes, you're welcome.
Thank you all so very much. And I appreciate participants today. Have had a lot to share. You may also know some resources. Any of the materials that we've seen along the way, we'll include an annotated deck, but you could even now think about putting in any other materials or links that we should have into the chat box. So we've been together for about an hour and 20 minutes now, learning a lot about design, implementation, and evaluation of digital health in advancing integrated care. And so wondering if it's already starting to have a little bit of resonance for you. Maybe we could launch this poll. Thank you. And so looking forward to seeing how you'd rate your knowledge as a result of today in this digital health space. So let us know. I learn a lot, but I really have to say that today a big difference to me has been the activation of patient, family, caregiver voice in the design, implementation, and evaluation all the way through. And I think, we saw that kind of user-centered design view, but I'm also, very clearly coming out of, not only user-centered, but actually user-driven, and how there's a real role for patients, family, caregivers to be playing in that implementation. Okay, we look at these results now, and as I'm going through, we don't have anybody down in the ones, twos, and threes anymore, and we have very few people in the fours and fives. So I would say that's a pretty resounding acknowledgement to the awareness and the discussion that's been brought about by just this one event today. So I really recommend that people have an opportunity to go look at the journal, read a little bit more in depth, and have a chance to explore some of these. And I did check, and it is available using this link for free for the next month for people to be able to go and access that. So great thanks to Axel Kane, who's on this event I did see, and Emerald Publishing for making this available to the IFIC Canada audience. It really is an amazing body of work that's been brought to bear here. And just to know that for people with more of a research, we will be posting up next week. We actually have Nick Sonnenfeld here from Vilans visiting us in Canada. And so IFIC Canada is going to host a talk here at the University of Toronto, which will also be posted online, well, not posted, but conducted virtually as well, so people can participate in that. And I'll just allude a little bit to our second coming out in June that we're planning on for IFIC Canada with next year's plans. So watch for the virtual community event happening in June. And I'll turn it over to Jodeme to close out for this one last part that she is so brilliant at.
Our favorite way to conclude our day, and knowing that we came together in shared purpose to learn from each other and to share information and knowledge and to strengthen the community. One word to share your experience today before you log off. And we put these together in a way that is accessible for everyone. Enlightened, grateful, connected, insightful, grateful, lots of thank yous, interesting, connected, encouraged, informative, community, Hence why we don't call it a webinar. We are really looking to create a connected community that learns from each other and helps make this world a better place through integrated care and through listening to what's most important to people and their families in this country and beyond. Thank you to all of our presenters and everybody that participated today. Wishing you a good rest of the day. Thank you from all of us.
Thank you, everyone.